your session, your lecture. So let me introduce Fabian, is plastic surgeon, and we will speak about amaurosis by HA.
Okay, thanks so much for the introduction. Well, I will start try to explain the way that I try to obtain a complete solution for amaurosis, even at least in our region, in Latin America. This is part of my brief CV. Okay. First, a scenario. Young patient with no reported history, HA facial filler a few minutes ago, look the clock. Present to the emergency room for eye pain and white eye blindness. Prescribing analgesic and anti-inflammatory because the medical doctor who received the patient didn't know how to deal with that. And he referred to the ophthalmology. But 4 hours later, our patient confirmed irreversible amaurosis. Our second scenario, same typical patient with a filler on the face. Again, go to the emergency room, but in this case, the medical doctor who received the patient have a little knowledge about that, and he asked for a magnetic resonance imaging that confirmed ophthalmic artery obstruction, and he referred to the interventional radiologist. But this interventional radiologist didn't know what is HA, didn't know what is IAL, and he tried to solve that with thrombolytic drugs. In the first 90 minute goal, even that, after 4 hours, the patient became blindness. Our third scenario, the young patient with the same maneuver, but in this case, this practitioner medical doctor, this aesthetic doctor, know what he need to do, and he quickly referred to the patient to the amaurosis center, treatment center, and go with the patient with 4 vials of IAL just in case. The magnetic resonance, of course, said that the patient have an obstruction of the ophthalmic artery, but in this case, the interventional neuroradiologist apply at the same time IAL and thrombolytic drugs. And in the first 90 minutes, that's why 4 hours later, our patient recovered completely his eyes and his vision. And this is not the worst complication. The worst complication is a stroke and death. Every 20% of the cases of blindness by HA have at least part of the brain artery occlusion with a stroke or, in some cases, the death. I introduce you with this young lady, is a medical doctor from dermatologist from Canada, Cathy last night, and he every 5 years makes research about all the cases of blindness in the world, the published cases. And in the last 4 years, he found 290 new cases. That means an increase of 500% in only the published cases. I suppose that every case that is published, we have at least 10 cases not published, because we are afraid to say we have a problem, because some cases the case is in legal situation, some cases because we are lazy, but there's a lot of excuse. But for sure, this number is more than that. A majority of the cases came from the East, China and Korea. But this is true, or that these people are really truly and they say the truth? We didn't know. With color, dark color, majority of the cases, light color, the less cases. But for example, my country, Argentina, is completely white. And this is not true, because we have cases of amaurosis. I know that. Majority of the cases is by HA, fortunately for us, because we have a solution. But 20% of the cases are for fat, and other cases of collagen, calcium hydroxyapatite, PLLA, don't have any kind of solution until now. Some people believe that it's safe using cannula. As Glasson said, this is not true. 42% of the cases of blindness came with the cannula. Fortunately for us, too, the first sign is vision loss. The patient says, "Doctor, I can see." The second is, of course, skin changes, but the pain is really characteristic, but only in 30% of the cases. As Glasson mentioned, this is the source of majority of the cases of blindness, nose, glabella, and forehead. And in words of Claudio De Lorenzi, this is plastic surgeon for Canada, I asked, how can I avoid this situation? And he said, slow and spared movement, inject slowly, low volume, and large caliber cannula. By this, of course, I prefer skin necrosis always than amaurosis, brain damage, or death. Because if I do it in opposite way, fast and localizing movement, inject quickly, large volume, and small caliber cannula, I want to obtain, I want to achieve a communication between external carotida and internal carotida branch, and the first terminal branch of the internal carotida is ophthalmic artery. That's why the patient became blind. I encourage you to read this Bible of injectors. Here is the QR to a free download. And there's a theory that we need to handle this situation. The theory said that we have 100 gold minute or 9-minute gold, it's the same. Inject with a cannula in the lower sternal quadrant, apply 105,000 units of YAL in a retrobulbar area, and etc., and etc., and etc. Well, I tried to doing that in a cadaver, and it's not easy. It's not fast. It's no loss of dangers. It's a really difficult maneuver in people that never doing that, and with a patient that is really anxious and with pain. This theory is true. They produce blindness in rhesus monkey, and they prove that after 98 minutes, they start to a complete destroy of retinal cells. That's why we all mention 100 gold minute, and this is true. And this is the step-by-step when you try to perform a retrobulbar application of YAL. But please, don't do it. Only skilled hands can do that. And even skilled hands have the possibility to damage the eyes, or the retinal artery, or the ophthalmic nerve. And here I am again with another cadaver, trying again. In this case, I use a needle. Even with a needle, it's difficult to me to perform the procedure. And imagine the patient with the movement, and I'm the first time to doing that. And there's another problem, because the retinal arteries are covered by ectodermal tissue. That's why the absorption is really low. We need to apply 2.5 centimeters, no more than that, because after that, we can have a lesion of the artery, of the ophthalmic artery, or the nerve. That's why it's really dangerous maneuver. All start with Chenot. Chenot have this publication in 2018, in which one he said that he obtained a resolution of blindness applying in the retrobulbar area. But in fact, he applied retrobulbar and periorbital area too. That's why we didn't know what really was the successful maneuver. And two different groups trying to reproduce that, and the conclusion was the author found no evidence of successful outcome of this technique. That's why, please, don't try it. Even in skilled hands, the anesthesiology apply in the retrobulbar area for some kind of ophthalmology surgeries. And even on his hands, with cannula or with needle, they obtain a lesion of the ocular globe. This is from courtesy for Cotofana to measure well the situation in anatomy. I have the great opportunity in my life to know this guy, Han Nguyen. I met him in 2023 in IMCAS Asia. After notice the way he solved this situation, I invite twice to my country, to Argentina, to teach us the way he solved this situation. I make a trip to Hanoi, Vietnam, visit him, and notice well the maneuver and the way he performed this procedure. And this is one of his publications. Unfortunately for all of us, he published really low really few papers because nowadays he had 22 cases of successful remission of vision, even in 2 cases with paralysis of the cerebral infarction. And you can go right now on IMCAS.com Academy, and there are no less than 5 different kind of lectures recording of his technique. And you can see step by step how can he reach from the femoral artery to the ophthalmic artery and apply 150 units of YAL every 10 minutes to obtain this recovery of the vision of the retina of this patient. The patient is awake, and he put the hands in front of the eyes. He moved the hands, and the moment the patient can count the fingers, he stopped the application. Even, I said, he recovered patient for palsy. And he gave an advice. Never is too late to apply YAL to the ophthalmic artery, because first you look for recover the vision. Then you recover the function. The elevator palpebral superior muscle, because the patient has ptosis. You save the eyes, and you save the glove, because it's not the same to have a glass or to have your own eyes, even if it's blindness. I offer you 2 solutions, Plan B, Plan A. I start from Plan B. I never will do Plan B. Plan B, ocular massage, anticoagulant, systemic steroids, blah, 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 and apply YAL, supratrochlear, supraorbital, and a supraorbital orbital quadrant, emerging point of the ophthalmic artery, 500 units in each one of these points. And here is anatomic situations. In a way, I found 4 millimeters from the rim and 14 millimeters from the canthus line, and it is immersed of the ophthalmic artery. But here is the proof, trying to use, thanks so much, doing with ultrasound, and we can find the supratrochlear and supraorbital artery. By this, if you apply directly to the artery, you can use less unit, as Leone proved to all of us, 50 to 150 units inside the artery. And here I am doing that in the cadaver. Again, it's easy to find the clot or the notch of the supraorbital artery. But I said that I have Plan A. Plan A is HA fast arterial salvage therapy. It means look in every big city of our country as referral center for amaurosis. The one in charge of that need to be the one who handle with the stroke, because every day of his life he go inside the internal artery. That's why for them are easy and faster to doing that. We need only to teach it how to deal and how to move and how to manage the YAL. That's why I said that all of us need to have this kind of signal with a call, with the number. We need to call urgently to tell to the expert that we have this amaurosis, and we go directly to the center. The center need to be in less than an hour of our office. And we need to go with the patient to present, and just in case, go with 4 vials of YAL. And here is step by step the protocol of Nguyen. You can take a photo of that. He go for a femoral artery. He apply 150 units in 2 millimeters every 10 minutes. He used thrombolytic agent. He preferred actives of Boehringer Ingelheim. He request to the patient stay in the hospital for 7 days, and he applied sodium heparin, 5,000 to 10,000 units every day, antibiotic, nitroglycerin, aspirin. And I called him yesterday, and heard about the average of the time this 22 patient came to the hospital. Unfortunately, came 3 hours, the average. That's why he can recover 20 to 40, 20 to 50 visual acuity. It's my acuity by my age. That's why at least it's something. That's why I offer you the Latin solution. Look for places to referral, to teach them the way to handle this amaurosis. Don't try to do it us. I want to have a session with multi-society in my country, cardiologists, neurologists, radiologists, plastic surgeons, and dermatologists looking for this solution, looking for places to refer this kind of amaurosis situations. And after that, in Panama, in Iberoamerica Plastic Surgeon Federation, I have a lecture trying to look at consensus in all the region. All Latin America need to have in every big city a referral center for amaurosis. Because if you don't care about your patient, I suppose, yes, you care about the patient, I suppose you care about yourself. Because in my country, a judge found a cosmetic doctor guilty of causing amaurosis in the patient, especially because the doctor didn't know how to deal with the situations, and he was guilty. My last take message, I have 1 minute. Exponential growth in the number of facial filler applications is equal of exponential growth in the number of amaurosis cases due to facial filters. Is 2 plus 2 is 4. 500 increase in 4 years. Imagine in the next 4 years. It's mandatory for all of us know about technique, know about the complication and how to deal with the complications. And of course, please try to spread that and look for amaurosis reference centers in the place where you live and you work. My final message, I hope you find you in Asia, in Bangkok, in China, and in Paris too. Thanks so much for your attention.